You first, because apa? Okay, traffic. We are 9 ini kan, 9 students kan ya? Ada semua dah. 1, 2, 1, 2, 3, 4, 5, 6, 7, 8, 10. Alright. So who want to present first?
Me, Doctor.
Sasha ya?
Yes.
Ini Sasha Xiaomi ni ke? Sasha ya kan? Sasha Xiaomi kan?
Yes.
Okay, alright. So what topic do you present?
Intravenous cannulation, intravenous cannulation and venipuncture.
Okay, alright. Proceed.
Okay, a moment. Right. Yeah, okay, sorry. Okay. Alright. So can you guys see my screen?
Yes.
Alright. So, okay. Assalamualaikum warahmatullahi wabarakatuh. So for today's procedure presentation, we are going to have 5 procedure presentations. Okay, so I'll begin first. I'm Shasha Mimi Maknawi, 1812-628. We'll be presenting on the intravenous cannulation and venipuncture. Okay, basically these two procedures are almost like the same things, but they are for different purposes. Okay, so this is my table of contents. Okay. Okay, so basically this is my table of contents, what I'm going to talk about today. Okay, so first of all, the indications, what they are used, why do we do this procedure? Basically for venipuncture, it is mainly for blood sampling purposes. Like we are going to take the blood for any investigations and we send it to the laboratory. While for the intravenous cannulation, mainly we want to give like intravenous fluid, medications or blood conveyance to the patient. Both procedures are very contraindicated in patients with any infections, fluorescence veins, burns, phlebitis, traumatic injury, or any surgical procedure. Common sites being used, common veins that been chosen for these procedures are the 3 veins, the basilic veins, the median cubital veins, and also the cephalic vein. Why these 3 veins? Because these 3 veins is visible, easy to be palpated, and also it is less painful to the patient. Okay, next, sites that should be avoided. Any sites that have scars from any burns, or sites from the arm on the site of mastectomy, any hematoma, bruising, or intravenous transfusion arm, or any edematous limbs. Why any edematous limbs should be avoided? Because it will be a danger of stasis of the limbs that can predispose to complications like cellulitis, or any sites of previous attempts, because it can give pains to the patient. For the equipments, more or less, they use the same equipments, almost the same equipments. Like we need the glove, we need the alcohol swab, the tourniquet, the needles, the sharp container. And if for intravenous cannulation, we will have the adhesive dressing. while for the venipuncture, we will need the blood collection tube. Okay, there are a few conditions that make the veins difficult to be accessed, like any in dehydration, shock, chemotherapy, intravenous substance abuse. For complications, both procedures may complicate to hematoma or bleeding due to arterial puncture, thrombophlebitis, dysesthesia because of median nerve injury, and also infection and pain. Okay, next I'll show you a video on how intravenous cannulation is done. Okay.
Hi there, I'm a medical student.
Okay. Okay. So first of all, like always, you need to introduce yourself first to the patient and
Can I confirm your name and date of birth, please?
confirm the patient's details.
Nice to meet you, James. Today I've been asked to insert the cannula into your arm.
Explain to the patients about the procedures and also gain the consent.
It might be a bit uncomfortable, but it won't be painful. Is that okay? For a doula, do you anything at all? I'll just gather my equipment and then we'll begin.
Okay, so after that, we prepare for the equipment. We need to prepare it on a clean tray. Basically, the equipment are the cannula dressing, alcohol swab, a pre-filled saline flash.
I'm Andrew, one of the medical students. Can I confirm your name and my equipment and then we'll begin?
Okay. Sekejap, sorry. Okay, back again. Okay. For the equipment, we need the cannula dressing, alcohol swab, pre-filled saline flush, a gauze, a tourniquet, a cannula, an extension set.
Yeah.
Then we need the glove and also the field. Oh,
Ah.
sorry.
Ini ya.
Udah.
Huh? Doctor? Sorry. Okay. After prepared for the equipment, then
Oh yeah.
like always, we need to don our apron and also the glove. Okay. Then proceed to prepare for the saline flush. After positioning the patient's arms, we need to inspect for a suitable vein. And then apply the tourniquet. Basically, it will be around 5 to 10 centimeter above the veins that we have chose. And then after that, we palpate. Sorry. And then after that, we palpate for the veins and clean the sites for 30 seconds using the alcohol swab. Allow it to dry. After that, again, hand hygiene, donning the glove, and then prepare for the cannula.
Okay, sharp scratch.
Okay. Alright. Okay. After that, we withdraw the introducer needle slowly and gently. And then we advance the cannula into the vein. Okay. After that, we remove the tourniquet first, then followed by removing the introducer needle. Okay. Throw the needles into the sharp bin. And then we attach the extension set. Secure the cannula with tape.
Yeah, I'm just going to flush the cannula out to let me know if there's any pain.
Right. After flushing the cannula, then we apply the dressing. And lastly, label the dressing using the date of insertion. Okay, and then that's all. After removing the glove and the apron, don't forget to wash the hands
Thank you,
and
James. Well
thank the
done. Are you feeling
patient.
okay? Yes, I am. Thank you. Brilliant. Thank you.
Okay, that's for intravenous cannulation. And for intravenous cannula, we have many types of intravenous cannula with different colors because it has the different functions. Like for example, the biggest one will be the in orange colors, which it is indicate for any trauma or rapid blood transfusion. And the smallest one is the yellow one. Most of the times we use for neonates or pediatric or older adult or in any routine blood transfusion. And also we have a purple one. Purple one is mainly for pediatrics and neonates. Okay, next, moving on to the venipuncture. Okay, again, hand hygiene. Don't forget to introduce yourself and confirming the patient details.
Nice to meet you, Amanda. Today I'm going to take some blood from you. Would that be okay?
Explain to the patient about the procedure and gaining the consent.
Might be a touch uncomfortable, but won't be painful. Is that all right? Yeah. Okay. Are you allergic to anything as well? Fantastic. Just get the mic equipment and then we'll begin.
And then prepare for the equipment on a clean tray. Okay, we need the tourniquet, we need the gauze, just like the intravenous. But then we have the blood collection device and the sample tube, the alcohol swab, and also the plaster. Okay, we inspect for suitable veins, basically from the 3 veins that I've mentioned before. And then we apply the tourniquet just above the veins that we have chosen. After that, we palpate for the veins. And then wearing the apron and the gloves. Okay. We need to clean the sides using the alcohol swab and allow it to dry, usually 30 seconds, in 30 seconds. And then anchor the veins from the below using the thumb at an angle of 30 degrees. Right. So after that, okay, this is where the things we call it the vacuum device. Okay, vacuum device will be inserted, and then we will push the bottles, the blood bottles that we have chose, into the vacuum device. Okay, and how to know that the needles are apa yang panggil? Correctly inserted into the veins or not. If the blood can fill into the bottles, the blood bottles just after can fill into the blood bottles, then it means that the needles has been inserted into the veins correctly. Okay. So okay, it will fill by itself until it reach the correct amount, and then it will stop. If you need another blood bottles, then repeat it again. After that, we need to remove the tourniquet first, then we followed by removing the needle and dispose it into the shop bin. Lastly, apply the plaster. Okay. After removing the glove and the apron, don't forget to thank the patient first. And then wash your hands again and label the samples at the bedside and seal it in a bag to transport to the lab. Okay, so basically that's for venipuncture. And lastly, for today, I'm going to show you about the types of blood bottles that being used for venipuncture. Basically, different colors of the caps of the blood bottles is for different indications. For example, like for the blue one, It is for any coagulation screen, INR for patients in warfarin. For the yellow one is called serum separating tubes. The yellow one is being used in can be used in many investigations. And also we have the many other colors. Okay, you can, okay, the links that are prepared on the right side, you can click on it to have more details about the blood bottle. So, okay, these are my references. And I think that's all from me. Thank you.
Right. Sasha, yeah. Thank you. Any question before I yang tanya? Any question? I think quite clear, yeah. A few things that we need to remember lah as take home message. So first thing, must be accept. You need to swap and even you need to use gloves and so forth. Yeah. Right. And then the second thing about the technique, yeah, the technique too. How do you prick the vessels too. Usually we do around 30-degree angle, ya. Of course ya, you need to choose the visible superficial vein. Tadi ada some common use, but tadi kan in adult kan ya. In pediatrics, in children, where's the common side that you know, Sasha?
I'm not so sure about it.
Side. The easier one is on the dorsum manus ya, belakang tangan tuh. Itu usually the easier one, but the size quite small kan, so that's why kalau dorsum manus tak dapat, usually kan kita naik juga tuh fossa cubiti, dan sometimes pun on the lower leg juga, on the other veins ya, yang kaki itu. Usually more proximal we go, the size of the vein will be bigger. So it will also determine our decision to choose the size of the granula kan. So commonly pakai yang size berapa kalau in children?
For the cannula? Oh,
Yes,
what?
cannula.
26. The pink,
small.
the purple one, or the
One the
yellow.
smallest kan. Even
Small.
saya pun tak pernah pakai smallest one ni, usually rare item lah, jarang nak dapat. Sometimes jadi mahal pula. Actually kan all the size tu should be similar price, but usually kalau rare item jadi susah nak dapat or expensive. Usually commonly ya yang next one lah, yang 24 tu, yang the yellow one. But one for baby, small child ya. Kalau yang bigger child, dah school age, adolescent ya, usually the blue one lah. Yang blue tu 22 ya.
Yes.
And then this one for only for fluid and usually for medication, but let's say you need blood transfusion, also need bigger size ya. Kalau boleh yang grey itu. Yang grey itu berapa? Dia 20 ke 18 yang grey itu?
Unit Sasha.
Berapa?
Yang grey 16.
Oh, 16 yang paling besar. Usually for blood transfusion, but kalau budak besar juga, kalau baby pasti tak dapat lah. Baby tu usually ya yellow or blue tu lah dapat. Okay, so itu ya di cannula, the size yang apa usually specific for children, and then as the technique also you need to remember that there is no such children that cooperative for IV line insertion ya. Ada yang akan macam in your video patient apa giving the hand and then okay. Even you pun kalau kena cucuk kan sakit kan, ada yang menangis pula kan. What more in children ya. So usually we will apa? If for ideal we should use sedation, give apa? Some oral chlorohydrate supaya patient tidur ke apa, tapi it will take time lah. So because the apa namanya prick tu the injection tu very apa usually very quick one kan. So biasa kita skip lah, tak payah sedation, just apa namanya some helper lah, sometimes parents, kalau parents takut pun ya we need apa 2 or 3 people ya tuh, yang another one to hold the baby or the patient. So yang itu and then another thing that you need to remember is the frequency. It is well known that it is difficult to insert kan IV line or to do even to vein puncture in children. We may repeat ya, kalau first attempt fail, we may repeat, but it is well known rule usually especially in a KKM hospital ya in Malaysia tuh. Please don't try multiple attempt more than 2 ya. First attempt fail, second time, and then makanya kalau fail 2 time tuh we need to refer or call a more senior or more experienced dokter ya. Kalau jadi hostman ya nanti udah 2 kali fail ya minta tolong MO lah. Unless kalau the patient very cooperative and then you see that apa you wanted attempt tuh patient okay, parents okay, and memang you betul-betul nampak di vein tuh. Kalau not sure, non visible atau very small vein, better you refer lah. Actually yang susah tuh nanti kalau in neonates lah. Actually neonates tuh very easy to see, tapi kecil lah the size. So need apa namanya precision. Lastly about the complication tadi udah sebut juga ya, the common one is phlebitis. Kalau let's say dah jadi phlebitis, what should you do, Shasha? Tak tahu.
Not so sure, doctor.
Ya, of course ya, we take off lah di cannula. First thing to do, take off the cannula. Sometimes phlebitis, sometimes apa namanya extravasation ya, dia rupture of the vessel tuh udah pecah, so tak boleh masuk lah the medication or the fluid. So need to take off first, yeah, and then you give another antiseptic apa namanya fluid pakai betadine tuh. Sometimes we need to give topical anti-inflammation, or kalau memang painful sangat ya bagi apa oral paracetamol pun jadi okay. Sometimes pun kalau dia apa very bad phlebitis biasanya kan develop fever ya. So develop infection kan, so we need to give antibiotic juga. Okay, and then lastly about vein puncture tadi more or less the same ya teknik. Just remember the bottle code ya, the color code of the bottles tuh. Actually most common kan kita pakai 5ABC, yang purple one ada EDTA EDTA tube, and then yang yellow one for biochemical parameters untuk pakai LFT ke RFT and so on and so forth. Yang lain-lain you baca sendiri ya. So any question for vein puncture and IV line insertion? Ya tak ada ya. So nanti next ni yang ini tak blood CNS taking tak? Sampling tak? Yang next presenter.
Ada lumbar puncture, doktor.
LP dulu. Nanti yang blood CNS, okay you present, tapi don't forget to also give comment about difference between common or usual vein puncture dengan blood CNS. Dia lain sikit di tekniknya. Bukan teknik lah, di procedures lah. Alright. So okay, second presenter.
Okay. For the second procedure is lumbar puncture that will be presented by me. Okay. So firstly, the overview of the lumbar puncture. So lumbar puncture is a procedure often performed in the emergency department to get for the cerebrospinal fluid. So lumbar puncture should be performed distal to the spinal cord at the level of the cauda equina. So at birth, the inferiority of the spinal cord is located opposite to the body of L3. So after that, the vertebral column grows more rapidly than the spinal cord. So as a result, by adulthood, the tip of the spinal cord is at the inferior border of the L1. So for the children that younger than 12 months, lumbar puncture should be performed below the L2 to L3 interspace. And for the older children, lumbar puncture should be performed from the L2 to L3 interspace to the L5 to S1 interspace. So when we need to do lumbar puncture, so it is usually for the diagnostic purpose, such as a life-threatening condition, such as the CNS infection, meningitis, or subarachnoid hemorrhage. It also used for the diagnosis and evaluation of the neurologic conditions such as Guillain-Barré syndrome and multiple sclerosis. It also can be used for the epidural and spinal anesthesia and for the infusion of the chemotherapy in patients with malignancy. And lastly, it used for the therapeutic purpose in removal the excess CSF, such as in the idiopathic intracranial hypertension. Next, the lumbar puncture is contraindicated when there are signs of the increased intracranial pressure, such as papillary edema. And second, when there are local infection at the lumbar puncture site, because when there are cellulitis or soft tissue infection at the lumbar puncture site, meningitis or other infection will be induced. And thirdly, when there are space occupying lesion, such as mass, abscess, when there are trauma to the lumbar vertebrae, and it is a relative contraindication when patients are hemodynamically unstable, such as children that with shock. So children with shock, they need to be resuscitated first before do the lumbar puncture. And then when the patient have the bleeding disorder, such as severe thrombocytopenia. So it is because the risk of the spinal hematoma. Okay. Next, for the procedure, first we need to evaluate, identify the patient, identify the condition of the patient first. So if the patient have the respiratory compromise, so we need to stabilize it first. And if patient have any signs of the increased intracranial pressure, this is the list of the physical findings that may suggest for the increased intracranial pressure. So patient need to should do the neuroimaging first. And then when there are signs of infection and spinal abnormalities, so patient with spinal abnormalities, they need another alternative to do lumbar puncture. So after that, we need to explain about to the patient about the detail, the procedure, and also we need to the detail of the procedure and how urgent emergency the condition of the patient, and we need to reassure the patient, reassure the parent. And the written consent is also advisable to be to get because the invasive nature of the procedure. But although it is invasive nature, but it is rare to cause the complication. Okay, so next we need to prepare for the equipment. So for the equipment, we need to prepare lidocaine, 1% without epinephrine. So this is for the anesthetic purpose. And then sterile drape, sterile glove, antiseptic solution, and sterile syringe with 25 gauge needle. It used for the injection of the lidocaine. And then gauge specs, manometer. Manometer is to measure the opening pressure, and for collecting tubes. And lastly is 22 gauge stylated spinal needle. So these are the guideline for the needle according to the age of the patient. Next is we need to put the patient in the position. So there are two positions, which are lateral recumbent position and sitting position. For the lateral recumbent position, as you can see in this picture, the assistant help the child to draw the knees upward and flex the necks using by the assistant arms. So then the patient position in the patient his knees and chin are flexed toward his or her chest, which are in the fetal position. But we need to avoid from the hyperflexion because it can cause a respiratory compromise. Okay, next is sitting. So sitting is preferred in patients who have the potential for develop respiratory compromise because of the hyperflexion. So the assistant grabs one of the infant arm and one of the leg in each hand while supporting to the head to prevent excessive flexion of the neck. So it is good because it improve the flow of the CSF in a small infant. But the sitting position doesn't permit accurate measurement for the opening pressure. So if the manometry is necessary, so sitting position should be avoided. Next is the preparation before the procedure. So first we need to do hand hygiene. So after the hand hygiene, we identify the injection site. So how to identify injection site? By palpate the midline vertebral column of the L4, which are at the level of the posterior superior iliac crest. So the above is we mark for the interspace of the above L4, which are the L3 to L4 interspace, and for the below is L4 to L5 interspace. After that, we go up and maintain the universal precaution by wearing sterile glove, surgical face mask, and head cap. And the skin, the patient skin should be clean with the antiseptic solution. So we apply the antiseptic in circular motion, starting from the entry side to the periphery. So we apply in circular motion, and then we apply the surgical sterile drape here, and then we inject for the anesthetic for the patient who need anesthetic injection. So we inject anesthetic to create the skin wheel, then we inject it to the deeper tissue. So after that, we insert the spinal needle. So before insert, we need to make sure the stylet in place. And then we position the spinal needle in the middle. And then we advance the needle slowly into the spinous ligament here, aiming to the umbilicus. So the buvette of the needle, so it need to face upward. Okay. Then a pop often is perceived when the needle penetrate the dura and enter the subarachnoid space because of the resistance. Okay. Then after that, we remove the stylet occasionally to check for the flow of the spinal fluid. So if there is no flow, we replace the stylet, rotate the spinal needle few millimeter and then recheck again. And if it is obstructed, or if the needle meet resistance, we withdraw the needle with stylet in place, recheck the position and reattempt the procedure. Okay, so after that, with a flow of the CSF, we attach the manometer. So here is the manometer. We attach to the hub of the needle by the three-way stopcock. So the manometer is functioned to measure the opening pressure. So once the pressure is reached, so then we remove the manometer and we transfer the fluid to the sterile tube. So once all sample are taken, we withdraw the needle. So after that, we wash the antiseptic solution of the skin and place a sterile adhesive bandage or gauze dressing over the puncture site. So these are the post-procedural complications that may happen uh, if we didn't do it safely. So the first complication is cerebral herniation. This is the most serious complication. It is because of the increased intracranial pressure. So in this patient, the lumbar puncture, it lower the pressure downward and the intracranial content shifted down to the pressure gradient. And then second is infection. Infection, as I stated earlier, because if there infection at the site of lumbar puncture, it can induce meningitis and other infection. And thirdly is spinal hematoma. Spinal hematoma is a complication where lumbar puncture is done in patient that uncorrected bleeding disorder. And these are the most common complications, which are the post-spinal headache. And after that, the another common is the back pain. So back pain usually resolve after a few days. And the rare complication are epidermoid tumor. So last but not least, before I end my presentation, I want to show a video about the procedure of the lumbar puncture. Can you hear this video? Yes. Okay. Okay, so that's all from me. Okay, is there any question?
Alright, any questions? Tak ada ya. Okay, for LP, again, aseptic, but it is need more sterile situation. It is more or less the same with blood CNS sampling ya nanti. How do you close the area? First of course the antiseptic is not only alcohol but need also chlorhexidine or betadine, and then need to close the area, only the small area, maybe around 5 to 10 centimeter diameter. And then itulah perform the LP. Before that also the location, yeah. Why you do on the on which level do you do the LP usually? Ada tadi explain what level of the spine?
L3 to L4 intraspinal space.
L3, L4 maybe quite low lah.
Or
Actually
L4.
L2 pun boleh. Okay, why on the lumbar, not on the thoracal, for example, or cervical? Kenapa, Aisyah Humaira?
Because the spinal canal and
Ya kan, semua spinal canal kan. Thoracal pun boleh spinal canal. Cervical pun boleh. Why not on that high level? Why on the should be L3, L4, maybe L2? Kenapa? What's the anatomy different of the anatomy of the nerve lah? Tak ada tadi masa present, saya pun tak ikut sangat buat tadi driving. Apa, anyone?
Sebab kalau makin tinggi, kalau tercucuk
Yes.
spinal cord, makin baik calculation dia.
Yes, on the cervical thoraca kan there is spinal cord kan. On the L2, 3, 4 ni dah yang L2 and below ni, L1 actually dah tak ada. It's only cauda equina. There is no more cord kan. Only the nerve fibers kan. So there will be less chances to break the cord lah. So itu yang different ya. Kalau spinal cord you break, so will be permanent damage lah, will be paralysis or maybe ya lah, ada permanent damage lah of the nerve ya. So itu tak boleh. So kena make sure dia L2 or below, tapi sakral pun dah tak boleh because in sacrum there is no space kan. So tak boleh cucuk lah kat situ. Masih usually memang limited on L2, 3, 4 tu. Usually we can go L2 first, and then kalau fail first attempt we can go downward. And then we go L4 kalau fail naik atas. By L2 first, and then kalau fail go downward yang lower side-nya. Okay. And then location tu kena well demarcated, usually on the level of sias ya. Sias tu superior. Lupa pula saya. Lupa lah. On the hip, highest level of the hip bone tu. kat situ. Alright, perform injection, and then of course the position of the patient must try to make the as big as possible the space tu. Intervertebral space tu kena as big as possible ya, as large as possible. So memang kena on flexion, neck flexion, like apa, an arc position ya. Boleh dia lateral decubitus atau buat dia membungkuk macam apa, macam bowing position kan. Okay, and then lastly yang you kena paham is the technique is which one do you prefer when you get the space tu, you go very near to the upper vertebra or very near to the upper lower side of the upper vertebra, or you go near to the upper side of the lower side of vertebra. For example, on L2 kan, ke atas dia kan L1, L2 tu atas dia L2, bawah dia L3 kan. Vertebra L2 and L3 ya, for example. So you go near to the L2 or go near to the L1. L3. Aisyah Humaira, ada idea? Di anatomy, this one important. Tak ada idea semua. So where is the vessels? Intervertebral vessels, vein and artery itu. Dia on the upper of the lumbal of the vertebra or on the lows of the vertebra, lower of the vertebra. Tak ada yang ingat. The vessel tu usually dia on the upper side of the vertebra. For example, dia L3, ke atas dia ada vessels. So kalau you not safe, because we should avoid the vessel kan. Kalau kita tercucuk vessel, vein atau kalau arteri, ya akan jadi hemorrhagic punya hemorrhagic punya sampel. Nanti result pun akan ada RBC, quite number of RBC lah, erythrocyte. So color pun sometimes jadi red kan, banyak darah. So kena go near to the, for example you ambil L2 tu, near to the L2 lah, ke atas dia. So that's why tadi nampak the picture tu kan, nampak yang dari tepi dia akan nampak near to the upper vertebra, ke vertebra atas dia, and then cucuk straight, and then the direction is not 0 degree horizontal position ya, relative to the vertebra, but actually the location is quite like upper angle ya, dia sudut ke atas sikit. You boleh bagi picture tak tadi, siapa ni, Aisyah Humaira? Share content balik tadi kok. Yang picture tadi of the ya. Ni kan, the degree is not 0 degree, tapi dia berapa nih angle nih? Saya pun lupa. Ada tak? The A itu berapa tuh angle tuh?
If I'm not mistaken, it's 30 degree.
30 ya, around 30 degree. So itu ya, kena remember yang that one. Because kalau you buat horizontal, nanti yang even though yang masa masuk dah dekat di vertebra yang atas, tapi masa before achieving the canal tu, you akan dekat tu di vertebra bawah dia. So akan kena vessel juga. So kena buat 30 degree tu juga also important ya, to avoid breaking the vessels. Okay ya. The needle size usually standard lah. Kita dah ada yang LP needle, but if no LP needle, we can use yang the macam injection needle tapi yang size yang besar lah, size 18. Okay, alright. Yang this one because it is quite apa namanya, even though sama-sama prick juga, but it's quite need well prepared lah. Patient must be full cooperative, so must be on sedation. Kalau macam vein puncture atau IV line kan pegang je kuat-kuat, hold the baby je, asal dia tak gerak-gerak, okay lah, dia menangis pun boleh. Tapi kalau LP, kalau dia gerak-gerak susah lah nanti, lah kena vessel, sometimes tak kena spinal canal, tak dapat nanti. Dan kalau menangis kuat-kuat jadi increase ICP, nanti jadi apa namanya macam tadi, herniation tadi. So try to avoid apa namanya crying, because crying pun akan increase ICP, akan ada risk of herniation. So ada indication apa ya, usually kan for apa to diagnose meningitis ya, infection. Contraindication of course kalau udah increase ICP. So how do you know? Actually kalau simple ya, using how do you know apa very high ICP?
Papilla edema.
So yang the easiest one actually papilla edema using fundoscopy ya. Fundoscope, kalau you tak pandai nanti masa on oftal punya posting tu belajar ya. Fundoscope pun actually not really early ya, because if the very high ICP papilla edema tu develop maybe later lah after few days. Sometimes kalau tunggu apa, even though no papilla edema, there is also very high ICP. So now the safe and apa namanya usual protocol before do LP, usually kan ED kalau patient indicated for LP ini, masa patient new apa come ya. Alright, masa patient apa come to the ED ya, we do CT scan dulu ya. With CT scan will easily evaluated lah. If there is very high ICP, there will be such apa level of herniation, brain edema, and apa and so on and so forth. So we usually do CT first, and then kalau on working hours ya we do LP sekali. But kalau on apa at night in apa after office hours, we usually do next morning lah, because usually LP sampling ni on working hours ya. But I expect kalau in weekend Saturday Sunday they should expect lah, tapi also usually at 8 to 5 hours juga. Kalau tengah malam dia tak nak receive lah di sampling. Okay. So another important thing, of course, ideally we do LP as soon as possible before we start antibiotic, because if we start antibiotic before LP, so there will be some changes in the findings kan. So nanti ada tak tadi present the findings, expected findings? Kan nanti je ada seminar on apa namanya meningitis kan, LP findings ada present tu. So usually bacterial meningitis, viral meningitis, or partially treated. Nah, so kalau partially treated tu looks like macam viral, dia tak jumpa the bacteria, but maybe still high cells and high protein. Yeah. So if we give antibiotic, may change the findings. Even sometimes looks like sterile, kita sebut sterile or aseptic meningitis. Yeah. But if usually if before antibiotic, we will get the organism. But if after antibiotic, it's difficult to get the organism. Okay, so I think that's all. As for now, at least you understand how to perform. You will not perform now, even final year pun we will not perform in pediatric ward andai kalau in adult, maybe kalau you in medical posting you boleh bantu sampling in adult patient, tapi kalau in children we don't allow lah, because high risk lah, it is quite specialistic punya procedure yang invasif ya. Your duty is only to observe and assist lah. Tapi kalau yang non invasif nanti ada kan yang these two tadi kan semua invasif nih. Invasif means you do something with needle kan. Invasif nih itulah we don't allow lah in pediatric posting. Only assist and observe. Don't allow to perform. But yang for non invasive procedure you should perform. Actually not me, but you should if possible you must perform lah, at least you have experience. Okay, all right, next, number 3. Aisyah Zulkarnain. So yang tadi panggil Aisyah juga ke Aisyah Humaira. Pak yang ini pasti panggil Aisyah kan, Zulkarnain nama ayah kan?
Yeah.
Yang tadi panggil siapa?
Panggil Aisyah juga.
Oh, aduh. Aisyah Humaira lah, kena dua-dua kan makanya. Kena differentiate. Yang ini Siti Aisyah, yang tadi Aisyah Humaira. Alright. Okay, you may start.
Assalamualaikum warahmatullahi wabarakatuh. So I'll be I am Siti Aisyah with this name. So I'll be presenting about the next procedure, which is the blood culture and sensitivity. Okay. So this is my outline. So blood culture and sensitivity is a laboratory test in which the blood taken from the patient will be inoculated into bottle which contains culture medium to determine the presence of microorganisms that causing the infection to the patient. So blood culture and sensitivity is indicated if if patient is suspected to have clinical symptoms of septicemia, for example, fever, especially if the fever, especially if the cause of the fever is unknown, and then chills, tachycardia, tachypnea, confusion, and also severe hypotension. So blood culture and it is also indicated in endovascular infection, systemic and localized infection, for example, meningitis. And also if there is unexplained leukocytosis and or leukopenia. So basically, blood culture and sensitivity is done. The aim of this test is to confirm the presence of microorganism in the bloodstream, and also to identify the etiological agent that causing the infection, and also it as a guide for antimicrobial therapy. Basically, blood culture is ideally it is done prior to the administration of the antimicrobial therapy. So it is to avoid unnecessary administration of the antimicrobial drug. So blood culture should be obtained via venipuncture because it has the lower likelihood of contamination compared to blood culture that is collected through vascular catheter. So the preferred, as mentioned by Shasha before, the preferred venipuncture site is the antecubital veins, which are the median cubital vein, cephalic vein, and also the basilic vein. Okay. So and the most preferred site is the median cubital vein. So for the
equipment in blood culture, apron, the equipment that are needed are the apron, sterile glove, tourniquet, blood sampling device, for example, the winch blood collection set, the blood culture, two blood culture bottles, which is the aerobic and also anaerobic. So this is the blood culture bottles. So in blood culture procedure, the device that is used to collect the blood is different uh, from what it is. It is the same as the venipuncture is involved, but the device that is used to collect the blood is different. So these two bottles are these two bottles are used in the blood culture procedure. So, and also other equipments are the sharp container, which is used to dispose the needles, and then cleaning swab to clean the venipuncture site, and then sterile gauze, sterile plaster, tape, and also laboratory form tables. And so blood culture procedure is a sterile procedure. So basically we have to be careful when we are doing the procedure to avoid an contamination to the collected blood, as it can lead to false positive results. Okay, for the techniques, just like any other techniques mentioned before. So before we start the procedure, we need to do the hand hygiene, and also, and then we need to introduce ourselves to the patient, and then and then check the patient's detail, such their names and also date of birth, and then we briefly explain to them what are the procedure that we are going to do to them, and also gain consent from them. And then we position them in a comfortable position, and then adequately expose their arms, and 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 we can also ask the patient if they have any pain on either of their hands, so that we can avoid from doing the procedure at the site where they have pain. Okay, so and then after we confirm the patient's identity, and then we will gather and check all the required equipment before starting the collection process. So and then it is also important to check for the expiration date, and also if there is any damage, especially the blood culture bottles. Okay, and then for the preparation of the inoculation, first of all, we need to wash our hands either with soap and water, or with alcohol, and then we will remove the caps from the bottle culture, and then we will disinfect the surface of the bottle with separate cleaning swab, and then we let it dry. We let it dry first, and then before we proceed with the bottle inoculation. So for the venipuncture, again we need to do the hand hygiene procedure, and then we will inspect the patient's arm for appropriate venipuncture site. So the most preferred site, as mentioned before, is the antecubital veins, and then we need to avoid areas that have bruises, or that is erythematous. And then after we inspect the patient's arm, and then we will apply the tourniquet, approximately 4 to 5 fingers width above the venipuncture site, and then we will palpate for the vein. So, and then we will palpate for the vein, and then after we identify the vein, we will don on our apron, and then do the hand hygiene, and then don with our glove, and then we will start to disinfect the venipuncture site with the chlorhexidine in the isopropyl alcohol, and then we will let the venipuncture site to be dried for approximately 30 seconds. If we need to repalpate the venipuncture site, we also need to disinfect again the site. And then we will insert the needle through the skin at a 30 degree angle or less, with the bevel facing upwards. And then this is the okay. So after we insert the needle, and then we will take the blood culture bottle, and then we will pierce the blood culture bottle septum to allow the blood to fill the bottle. So in blood culture procedure, we need to fill the aerobic bottle first. It is to ensure that the air will be removed from the needle and tube, and then we will allow the bottle to be filled with the blood, with 10 millimeter of blood in adult, or 3 millimeter of blood in pediatric patient. So after we have done with the aerobic bottle, and then we will attach the anaerobic bottle to the and then allow the bottle to be filled. So after we have done with the procedure, so we need to dispose the needle into the sharp container, and then we will cover the puncture site with an appropriate dressing, for example with cotton wool or gauze. And then after that we will remove glove and apron, and then we will wash our hands. And then before sending the blood sample to the lab for analysis, we need to check the label and also the forms for accuracy. And then we do not cover the barcode on the bottles with patient's label. And then it is important to put the blood sample in the biohazard bag to avoid leaking. Okay. So that is all from me. What we need to remember is that in blood culture procedure, it is a sterile procedure, so we need to be careful when doing the procedure. Basically, it is to avoid contamination of the blood sample, because it can lead to false positive result. Okay. So, and also the complication would be the same as stated by Shasha before, because it involved the venipuncture procedure. Okay, so that's all from me.
Alright. Any questions? Selalu tak ada yang tanya, yang lain senyap. Pening semua nak present. Okay, so take notes ya, take home message. Unlike vein puncture, kalau vein puncture only antisepsis kan, only clean the skin tuh with alcohol, and then as long as the needle tuh sterile, okay. Yang glove tuh tak sterile tak apa. But for blood sampling, all the equipment must be sterile. Even the antisepsis pun must be 2 step lah. Not only alcohol swab, but also yang chlorhexidine tadi. So chlorhexidine dulu, baru double with alcohol to clean and dry the skin. Okay, and then all the equipment must be sterile, including your glove. And then kalau you nak pegang patient pun must hold on the bukan clothes, on the ada sterile punya yang untuk tutup location tadi. Itu ya. Actually kenapa kena sterile? Kalau yang tadi kan, kalau yang untuk blood vein puncture untuk ambil blood sampel kan oke aja tanpa sterile. Even though actually we also confident kan with vein puncture pun actually we can get the sterile punya sampling blood. But for the blood CNS kenapa betul-betul sterile equipment?
To avoid the blood sample from being contaminated with
Yes,
the
it's very
normal
simple
flora.
thing. Jangan sampai contaminated, because kalau yang masa untuk ambil FBC ke renal profile ke, we don't send to the microbiology, even though ada kontaminan bakteria will not disturb the result. But for blood CNS, we want positive culture. It is really truly positive from the blood of the patient, not from the contamination. Usually kalau contamination itu ya normal flora kan, on the skin, your skin atau your hands tuh, atau the patient skin ya. Kalau contamination jadi normal flora tuh of course kan common kan, will be cons ya, coagulus negatif staphylococcus or strep ya. So to avoid contamination. And then another thing, usually in pediatrics usually we use aerobic bottle only lah. Yang anaerobic tuh only for indicated case. Kalau for adult kan maybe kerap ya anaerobic, because in children tuh most likely primary infection ya it's aerobic bacteria. Color apa? Soalnya for aerobic bottle tuh. In children kita usually memang spesifik lah. Pakai satu color aja. Color apa? Bottle. Bukan warna hijau tadi.
Is it silver?
Huh?
Silver color.
No,
or pink?
the bottle is yellow.
Oh, yellow. Okay.
Yellow color usually. This one the faktor itu Bactec punya bottle lah. Dia untuk bacterial culture. Okay, little bit lagi backward with the background indication. Of course, any suspected bacterial infection ya, because blood culture kan specific for bacteria. If you want to isolate the virus, viral isolation of also blood, but we don't do blood bacterial culture, not use this bottle lah. Viral isolation is much more difficult. Usually for this blood culture and sampling too, we only able to get bacterial organism. Ya. Maybe fungal boleh nampak juga kalau nanti on the microscope sometimes akan nampak. So indication simple ya. Any suspected bacterial infection, meaning any cases that patient of course usually fever kan, and then any cases you start antibiotic. Before you give antibiotic, please take the blood culture and sensitivity. Yeah. So that's why even the pneumonia case pun we also send blood CNS. Pneumonia kan actually the infection is on lung kan, on the respiratory, but we also send blood CNS. So that's why nanti kalau result pun pneumonia most likely the yield is slow lah, most likely blood CNS negatif kan, no growth, because the organism is actually on the airway and lung. Tapi kita send juga because in pneumonia we usually start antibiotic. In other infection pun macam for example UTI pun, if you want to start IV antibiotic kena send blood CNS juga, because we want to make sure there is no bacteremia and or septicemia. Because if we take blood CNS after IV antibiotic, so usually itulah akan sama macam LP tadi, bukan akan result lebih negatif lah. Kalau LP kan despite culture, we also take the analysis kan, akan keluar protein, cells, glucose. It's okay even though culture negatif. Tapi kalau blood CNS memang we just take the culture. Kalau blood CNS negatif kan meaning there is no bacteremia. So that's why we don't want to get negative culture after antibiotic. Kalau you nak take make sure what is the organism, ya kena before antibiotic ya. Yang usually itulah kena early, yang the one that difficult tu in severe sepsis situation, because patient even the gold standard of treatment severe sepsis tu we must start antibiotic within 1 hour. Even since in emergency better we start antibiotic. So that's why kalau in severe sepsis for more septic shock kena ambil blood blood CNS in ED lah. Tapi kalau stable patient usually we transfer to the ward first, ambil blood CNS baru start antibiotic. Okay, so I think that for 3 ya. Another 2 hari ini. Siapa nombor 4?
I will be presenting next.
Okay, Nurul Putri. Okay, go on.
I hope everyone can see this and hear my voice. Okay, so I will be presenting on nebulizer and MDI. Let's start with nebulizer. Nebulizer is a machine that turns liquid medication into fine mist and inhaled with a face mask or the mouthpiece. And the process of using this machine is called as nebulization. And the indications of nebulizer is for children with acute asthma attack, children that present symptoms of respiratory distress, children that present with stridor, and in cases such as the drug is not available in the inhaler preparation, as well as to treat or control persistent infection. The contraindications of nebulizer is patients with unstable and increased blood pressure, individuals with cardiac irritability, as well as those with increased pulses, and unconscious patients. Unconscious patients because the medication is used to is required to be inhaled. So if the patient is unconscious, then the respiratory rate of the patient may drop. So that will affect the effectability of the medication. Moving on to the basic structures. So these are the basic structures of the nebulizer. We have the machine, the hose, the medicine cup, the mask, or the mouthpiece. The difference between using the mask and the mouthpiece is that first, for the mask, we usually give for patients who cannot hold the mouthpiece well. And since the mask has this strap, so the mask can seal the area around the nose and the lips tightly, hence reducing the risk of medicine leak. However, it could be uncomfortable for some people. For the mouthpiece, we usually give mouthpiece for patients that we are confident that they can hold well. And the problem is that patients have to remember to inhale deeply through mouth and exhale through nose. There's also risk of medicine leakage because the patient is needed to seal the mouthpiece tightly around their lips. However, it is easier to clean as compared to the mask. Moving on to the procedure, it's basically summarized in this picture. For the first and the second step is not shown. So the first step is to put the compressor on the machine on the flat surface possibly it is better to be near to an outlet, and make sure all the pieces are clean and wash your hands before preparing the medication. Then we can start on filling in the medicine cup with the right prescription in dosage. If the medicine is pre-mixed, simply put the medicine in the medicine container of the nebulizer. If it is not pre-mixed, then measure the medicine correctly using syringe and a dropper. Then picture number 4, make sure to close the medicine cup tightly to avoid the medicine from spilling over. Then connect the hose to the nebulizer. and then connect the mouthpiece or the mask to the top of the medicine container. Then connect the medicine cup to the nebulizer machine using the hose. Then, using the strap, make sure the mask is firmly placed over the nose and the mouth, leaving no gaps. Or if you use mouthpiece, then put the mouthpiece into your mouth and close your lips around it. Make sure that there's no gaps too. Then turn on the nebulizer machine to check if it is misting. And then inhale and exhale slowly until the medicine is gone. And this may take 5 to 15 minutes. Then make sure that during this process, make sure that the liquid container, the medicine container here, is upright throughout the treatment. Moving on to the care of the machine. So how can you take care is that first is to disconnect all 3 components, then wash with warm soapy water or mud detergent, then rinse, dry with paper towel. The filter of the nebulizer must be checked, cleaned, and replaced regularly. And if your nebulizer, if one of your components of the nebulizer machine, especially the hose or the mask or the mouthpiece, you notice there are some kind of spots or discoloration, it is better to discard them because there might be risk of contamination. Then the medication that we use for nebulization is first, there are a few types. First is bronchodilator, for example, salbutamol, for conditions such as acute exacerbation of bronchial asthma, acute exacerbation of chronic obstructive pulmonary disease, and severe asthma. For corticosteroids, such as beclomethasone, is used in severe asthma. Anticholinergics, such as ipratropium bromide, have the same indication as the bronchodilator. Antibiotics, such as rhabdomycin, colistin, azithromycin, can be used in conditions such as chronic purulent chest infection. Moving on, these are the side effects of the medication itself. So for salbutamol inhalation, it may cause palpitation, anxiety, mild tremor, dryness of mouth, headache, and hypertension. While for anticholinergic inhalation can cause blurred vision, decreased intraocular pressure, acute or worsening narrow angle glaucoma, as well as cataracts. Okay, so that is for nebulizer. Moving on to the metered dose inhaler, MDI. It is a medical device that administers medication to the lungs in an aerosolized form, and the medicine is administered in a metered dose, which saves the users from having to measure their dosage. Okay. The choice of inhaler depends on the ability to use the inhaler. So this, we have to take note of the patient's age, the type of medications used, because different types of inhaler have different colors. Adherence, that means we could prescribe them daily instead of twice daily dosing to improve compliance of the patient. Of course, the cost of the inhaler itself and the patient's preferences to use inhaler. The inhaler can be used in asthma, chronic obstructive pulmonary disease, and other respiratory conditions. The contraindications of using an inhaler is that patient with airflow obstruction due to inhaled foreign body and airflow obstruction plus acute myocardial infarction. Why cannot be used with patient in airflow obstruction? Because just like nebulizer, the medication used in MDI is needed to be inhaled into the lungs. So when there's airflow obstruction, then the medication cannot go to the lungs. So that is why. Moving on to the basic structures. So this is the cross-sectional structure of the MDI. We have the canister here and the mouthpiece part. So the canister, we have the metering valve to measure how many dosage, as well as the actuating stem. This actuating stem to release the droplets of medication. And usually this actuating stem has its own dust cover. Okay, and then the mouthpiece. So in some patients, we can also give them MDI with a spacer, and this is usually in children that have poor coordination to push the canister. We actually push the canister to let the medication out, to push the canister down and breathing in between. So this will help them. So these are the procedure according to the picture. First is to shake well in an up-down motion of shake the inhaler well in up-down motion before each puff to make sure that the medication is mixed well. Then remove the mouthpiece cover of the inhaler and hold the inhaler in an upright position. The patient must sit or stand up straight and tilt the chin out. And then hold the inhaler upright with your index finger on top of the canister and your thumb supporting the bottom of the inhaler. Then you have to breathe out slowly and completely through your mouth away from the mouthpiece. This is before you put in the inhaler into your mouth. Then only after breathing out slowly, then only you place the mouthpiece gently between the teeth without biting. Ensure a tight seal of the lips around the mouthpiece. However, do not block the opening of the mouthpiece with your tongue because the medication will come out from there. Then breathing in slowly and deeply through your mouth while at the same time pressing down firmly the canister once. And then continue to breathe in slowly and deeply for around 4 to 5 seconds until your lungs are full of air. Then remove the inhaler from the mouth and hold your breath about 10 seconds or as long as comfortable. And then breathe out slowly away from the limited dose inhaler and wait about 30 seconds and repeat the step for subsequent puff. Then replace the mouthpiece cover after use and rinse your mouth with water and spit it out, especially for a steroid containing inhaler because it may cause some side effects. Okay, so this is a procedure with spacer. It is basically the same thing except an extra step where you have to insert the inhaler into the spacer and open the mouth cap of the spacer. Okay, moving on to the care of the inhaler. You must always clean at least once weekly the inhaler. So first step is to remove the mouthpiece cover and the canister from the actuation body. And remember to not use detergent or soap in the process of cleaning the inhaler. What we clean is the white thing. This one is the canister cannot be cleaned. Okay. Then wash this is called as the actuator. Then wash the actuator from the top with the running tap water for around 30 seconds and repeat by running tap through the mouthpiece of the actuator, the mouthpiece, for 30 seconds. And then let the actuator dry overnight after shaking off as much water as possible. Then when the actuator has dried, assemble the canister to the actuator body again and ensure a tight fit. Shake the device well and actuate twice away from the face to ensure no blockage. Then replace the cap and store the device safely before the next use. So in case in people with spacer device, so this spacer device has to be cleaned once a week with warm water with mild cleaning detergent. Drip dry naturally in room air and do not microwave the spacer to dry it. And we have always to be cautious not to rub the internal surface of the spacer with brush or cloth because this will damage the surface. And do not use hot water to clean the spacer or harsh detergents such as chlorine because this will damage the spacer. Okay, the medication used or in this context, the types of inhaler we use, we have reliever, which is colored, which is blue colored, and a controller, which is like a green teal color. So reliever, the medications involved is either short-acting beta-2 agonist, salbutamol, or anticholinergic, ipratropium bromide, and the function is to provide immediate relief. For controller, we basically give corticosteroid, mainly budesonide, and this is for long-term control of the mainly asthma. Okay, these are the side effects of the medication. Palpitation and tremor, like we have mentioned before, due to salbutamol, and it can cause tachycardia and tremor, especially if it is given in high dose. Oral thrush can be caused by steroid inhaler, and oral thrush is actually oral candidiasis, and this is mainly because of the patient who do not wash their mouth effectively after usage of the inhaler, steroid inhaler. that is all from me. Thank you very much.
Alright, so like yang spesifik for MDI in pediatric actually not in certain situation actually it is routine lah in all children we must use spacer because it is not effective if we only use MDI to inhaler in children ya. So dia tak akan boleh. How do you actually use inhaler tu?
Use inhaler.
Kalau inhaler without spacer tu only inhaler je.
Oh,
MDI.
kalau without spacer is this lah the main thing lah. Shake it and then.
Okay. Masa administration macam mana?
Oh, masa administration, first you have to breathe it out, and then you put the inhaler in your mouth, and then as you push the inhaler, you breathe in.
Deep breath ya, kena apa? Force bukan force, kena deep inhalation ya, deep apa namanya? Inspiration ya. Which is it is nearly impossible lah in children. Maybe kalau udah adolescent is okay ya, but in children what more yang below 5 it will not possible ya. So memang it is routine ya, in all children we use spacer because kalau use chamber nih the spacer we just only need to push the inhaler to the chamber and then the child will breathe normally. Yang penting kena tight seal. So how do you know the tight seal? There is a valve. Itu kena nampak gerak-gerak masa dia napas ya. The valve must be moving. And then apa instruction masa buat after if using air chamber nih?
After
masa administration macam mana? How many breath, how many second? Ada tak?
This one for around 10 seconds.
Around 10 seconds tu actually 5 breath cukup lah. Jangan suruh 10 napas. Kalau 10 breath terlalu banyaknya. Usually 5 breath is adequate lah. So every pump, every satu kali pump tu one puff. Ask the parents to count the breathing of the child. So 5 breath is enough per puff ya. So it is much simpler for children ya. Kalau without spacer it is impossible ya. Okay, and then another one is of course nebulization ya. Nebulization it is a known procedure in the ward, but before COVID era. So dulu in our protocol tu and every child with bronchospasm, bronchoconstriction we use bronchodilator nebulization. Kalau no spasm maybe nebulize with saline lah. Okay, but now in COVID era the important thing we cannot nebulize patient unless kalau ada confirm negatif COVID ya, because nebulization is aerosol generating procedure ya. When you nebulize your child tuh masa keluar aerosol tuh adalah it's aerosol generating. If COVID patient you nebulize, so the virus will go with the aerosol. Dia akan flying on the air. So it is not allowed now ya. Even in the ward pun kita pakai MDI sekarang ya. So it is the important thing that you must know now for the current practice. Unless kalau usually we call it in severe asthma attack, for example, severe exacerbation. We call it rescue nebulization. So memang sometimes MDI itu dia not that effective to deliver the medication kan, karena usually the dose is quite small ya, one puff to only 100 microgram. Kalau pakai naps tuh, you can give 2.5 to 5 milligram, which is berapa kali itu? 25 to 50 times more than MDI. So itulah but only for rescue lah, if in very severe situation. But if patient stable respond to MDI, ya we use MDI. Oke, so yang nomor 5 nih kayak apa nih? Tapi kan Mbak Dah ini udah anak maghrib kan? Can we stop and then yang nomor 5 nanti ikut yang hari Kamis on Tuesday. Yang nomor 5 apa?
OJT and AJT.
Boleh tak? Apa nanti Thursday je?
Boleh je doktor.
Oke ya. Okay, so we proceed nanti Thursday morning. Thursday tu I'm quite free lah. Maybe early around 8:30 or 9 pun we can start lah.
Friday morning, doktor.
Sorry, Friday ya.
Yes.
Kamis pagi you ada kelas tak? Tak ada kan?
Tak ada.
Hah?
Tak ada.
Tukar Kamis tu kalau boleh. I thought it is Thursday. I will check lah. I will check my schedule. I think Thursday I'm free. Okay lah, so nanti we change to Thursday ya. Yang di Zoom ni yang apa Farah yang bagi, departemen punya, yang Dr. Syahal punya.
Yes, doktor.
Okay lah. Alright. So okay lah, so minta Farah maybe kalau ada class with other class ya, you Farah akan give Google Meet lah, Gmeet punya link. So okay lah, mana-mana boleh. Alright, okay ya. So we close our session this afternoon with Taufiq for an answer. Alright, thank you all. See you on Thursday ya, morning ya, Kamis pagi. Okay, thank you. Assalamualaikum.
Thank you, doktor.
Assalamualaikum.
Salam.
Salam.